Welcome back to NAA's Mental Health Awareness Week. I'm your host, Tiana Heath, the Senior Manager of Industry Relations with NAA, and we are back for day two of our four-part series this week on mental health. Just a little housekeeping. NAA's antitrust compliance statement is on the NAA website where you can review it at any time. If you have any questions, please reach out to any NAA staff member, and just remember, our information today is for educational purposes only. All right, with that out the way, let's dig right in. Mental health continues to be a priority at NAA. We hope to shine a light on this topic and be a thought leader in this space. We strive to bring resources to our members, not just during Mental Health Awareness Week, but all year long. Our Let's Talk About It campaign earlier this year moved many and had a positive impact, sharing our unique but relatable stories. Today, we have another fantastic speaker, Phil Rutherford, Strategy Lead, Substance Use Disorders at the National Council for Mental Health and Wellbeing. The Council has been kind enough to partner with us over the years to bring our association's timely and relevant information to all of our members. After today's session, head over to the Mental Health Awareness um, website for more information and resources, and I will also drop that link in the chat. Without further ado, Phil, please come forward.
Perfect. Hello. And gonna share my screen here and hopefully we get the right version. Okay. So can everyone see my screen? And I guess I can't hear you, but I can get a thumbs up or thumbs down from Jennifer.
We are good to go.
Okay, perfect. So welcome. My name is Phil Rutherford, and as was said, I'm the strategy lead for substance use and also a person in recovery. And so I want to start today's presentation with just with a question, and you're going to have to reply in chat. But what I'm interested in are observations that people on the call may have had about people with substance use disorder. And so, to be clear, you're not going to offend me. This is my presentation style is pretty laid back. I'm not super worried about being offended. So I've got some observations that I've heard. And actually, there's a picture on the right there of a face plant or face palm. And I've actually seen that look from people around me. So, but let's go through these. The basic lack of willpower. They need to make better choices. They're weak. Feel free to put some in the chat if that is to your liking. So they don't care about themselves. They don't care about their job, their spouse. They have a problem. They need help. And I've got a question mark there because there's probably plenty of other things. But all of these things are things that I've heard personally about substance use disorder. And one of the things that I never do is I never try and convince anyone of anything. What we're going to talk about today is just sort of basic science and information that we actually know about substance use disorder. So our agenda, we're going to talk about acute and chronic conditions, behavior and cycles, neurobiology. So I don't know if you were planning on having neurobiology on a Tuesday afternoon, but you're getting it. And also how the brain gets hijacked, because it does. And then we'll talk through some supports. So away we go. Acute versus chronic conditions. So, and this is sort of a baseline in order to really understand what we're talking about when we're talking about substance use disorder. Acute conditions develop suddenly and last a short time. Those are on the left. You can see some of them: common cold, strep throat, broken leg. Whereas chronic conditions develop a little bit more slowly and typically get worse over time, but they stay with you. So those are things like hypertension, diabetes, arthritis, epilepsy, heart disease, and cancer. I added a few things to the list, and again, this is where we get into the sometimes people have very strong opinions about what the condition is. However, it is it is identified. Substance use disorder is a chronic condition and it sticks with the person over a period of time. Now, the goal in a lot of treatments is to get to remission and to get to a place where the symptoms are not causing a problem. But substance use disorder is definitely classified as a chronic condition. Also, an overdose is an example of an acute thing, something that happens suddenly. So let's talk about treatments. And this will make sense as we go through, but the way that we treat a lot of these things is with pretty simple solutions. So like for a common cold, rest in fluids. If you got the flu, there's antiviral meds, and that's actually a development only within about the past 20 years. But if you have appendicitis, we take it out. And the thing about all of these items is once the treatment is applied, the condition is satisfied. Obviously, unless the patient no longer lives. But in most cases, when you take the medicine as directed, you get a result. Chronic treatments are more about getting rid of symptoms. It's about remission of symptoms and progress toward being symptom free or remission. So, for example, hypertension, we've got ACE inhibitors, we've got beta blockers, diet and exercise. The thing for a lot of these conditions is diet and exercise. But the medications, though, are usually very helpful. Like for arthritis, we look at NSAIDs. For cancer, we look at chemical or radiation therapy, vivisection, where they actually remove the part that's bad. Um, and there's medication for substance use disorder as well. So, and I have some, and I recognize I've got some technical terms in here, but what we do to treat opioid use disorder, for example, is we use a drug that's called an opioid agonist or an antagonist. So what that means is that it simulates a little bit of the sensation of the drug, but it also prevents additional consumption of the drug. Things like buprenorphine make it really difficult for you to continue to use the drug, the opioid, other than buprenorphine. There's a drug called acamprosate. This is for people with alcohol use disorder. And then there are the more traditional things that we understand to treat SUD, and that's therapy, mutual aid groups like Alcoholics Anonymous, Smart Recovery. There are a number of them. But those are the treatments for substance use disorder. And like other chronic conditions, substance use disorder is treatable. As a matter of fact, it's got higher recovery rates than some of the other illnesses on this page, but it's certainly on par, the recovery rates. Moving right along. So just a quick, there won't be a test on this at the end, but just there's a way to identify or diagnose substance use disorder. And there are 11 criteria. There's a book called the DSM-5, and it's the way that psychiatrists and other mental health professionals identify disorders. So what you're looking at are the things, and these aren't the exact, this isn't the exact wording of the DSM-5. These are just things that are kind of maybe a little bit easier to understand, but basically like wanting to cut down, but not, spending a lot of time getting, using, or recovering, not managing work, home, or school responsibilities. These are all things that identify someone with substance use disorder. Now, for the diagnosis, you only need two to be considered with mild substance use disorder. You only need two. For moderate, you need 4 to 6, and for severe, you need 7 and up. And so these things, and again, I don't know this audience all that well, but you can look at these and see if some of these things happen. Most people develop tolerance of some sort, even to alcohol, because it's a substance, it works a certain way in the brain, and we typically want more. That does not make you a person with substance use disorder. But you add one more thing to this. So using substances again and again, even when it puts you in danger, continuing to use even when you know you have a problem. These are all things that really sort of lean into substance use disorder. And the truth about it is it's more of a continuum. It's not a binary thing. So a binary thing would be you're pregnant or you're not. the type of substance use disorder that you have or the severity level can change. It can change over time, and it usually there's an element of progression to it. So um, those are the descriptors of substance use disorder. But I want to talk a little bit about how it actually works in the brain. And so we're going to start with a couple of things. Binge use or intoxication, using that drug over time does something to your brain. Um, Typically, by the way, just for anyone that's in here, if you've ever had a really bad hangover, one of the things that you're experiencing there is a bit of withdrawal from the substance. Now, again, this does not mean that everyone that has a hangover has substance use disorder, but that is what your body is saying. Your body is saying, "Hey, I've got something in me. Either I need more of it, or or I need it all out." And basically that is withdrawal. Craving and planning is and this is really where we kind of lean in more to substance use disorder. Craving and planning, an increase on getting the substance. And what this actually does is it creates a cycle. So it's sort of, as you have the substance, then you withdraw from the substance, then you have an idea that you want more. And then you consume the substance, and so on and so forth. So it's a bit of a cycle, the way it works in the brain. So in terms of the way people feel when they're doing this, in the intoxication period, you typically feel good. In the withdrawal period, you don't feel as good. And then in the craving and planning, you're kind of looking forward and obsessing about consuming the substance. And again, you've got the same cycle is still running. And that this is sort of what's happening in the brain. The way it works in terms of mood, and hopefully I'll have a video for us to watch at the end that talks a little bit about mood. The way that it works in mood, and by the way, when I say substance use disorder, I'm talking about all the substances. There's actually a pattern of behavior associated with caffeine addiction. That there's and if you're here and you like a good strong cup of coffee every day, and then you miss it for a day or two, sometimes you'll get a headache. That's a withdrawal symptom, right? And your mood may be affected. So if we think about substance use and repeated substance use over a period of time, this is what happens. The chart that you see is, so you sort of start at flatline, right? That's your basic mood. Substance use makes you feel a bit better. And over a period of time, as you'll see going through the various uses, you'll see that the baseline, like where you start, is below where you were in the beginning. And this is really one of the things that starts to highlight the development of substance use disorder, because you're trying to get back to this initial peak. You're trying to get back to this thing, and you'll notice this peak does not occur again with continued use. It's like the brain is sort of the ultimate thermostat, and what it does is it tries to keep equilibrium. It tries to keep you at sort of a baseline mood. Use of substances make that more challenging. So now we're going to go a little bit deeper. We've talked about what it is. We've talked about how it works in terms of use and what is on the outside. Now I want to kind of shift a little bit to what's on the inside. And what's on the inside, I mean, your brain is essentially, like I said, it's a thermostat. It's trying to keep equilibrium. It's also trying to process signals coming in and out and generate behavior. So we take information in, and I think the best way to understand this is, if you've ever burned yourself or put your hand on something really hot, there's an immediate response, and it actually happens before you consciously think about it. But you immediately reflexively snatch your hand away or snatch your arm away from whatever is burning. That is a complex set of electronic signals that travel through your hand into your spinal cord up to your brain. The motor response in your spinal cord is the thing that snatches your hand away. That actually, you don't have to have conscious thought for that. It just, the brain does what it does. It's a pretty complex device, as it were. So what we're looking at now is inside the brain, and those little sort of sparkly things there. And here, I'll start the video. Those little sparkly things, those little dots of light, those are your neurons. And as far as things go, our brain is one of the most complex machines in the universe. Um, we have about 86 billion neurons in our brain, and there are more than 100 trillion connections there. Sometimes you'll hear a stat that there are more neurons in our brain than there are stars in the Milky Way. That's not exactly true, but short story, there's a lot of them. And what's happening in the brain specifically with substance use, and here I'll get a little bit better picture, um, is that there are our brain over a period of time has developed a way to mark behaviors, right? So some of you may have heard about the pleasure center in the brain and things that feel good, and that was an early understanding of what was happening when people are using drugs. But because of images like the one you saw before, we know that it's not so much about pleasure. The messaging that is going into your brain when you use a substance is that it says to release dopamine. Dopamine is incredibly important in our brain because it's how we remember things. It's connected to our survival instinct. And it when something happens, we mark it with dopamine, and it says, hey, that was whatever that was, you need to remember that. And I guess um, if you think about sort of caveman times, when someone was doing trial and error on food, if they found something that tasted really well and nourished them, the brain produces dopamine to sort of mark that. Because remember, back to the previous slide, um, these are simply our entire being is built on those neurons and built on the electrical signals and the neurochemical signals being sent back and forth. So dopamine is the thing that says, hey, let's do whatever that was, let's do that again. And for whatever reason, the substances people consume, including alcohol, including caffeine, tell the brain, hey, that's important. What happens with substance use disorder is that system gets out of whack, and it gets sort of stuck in this mode of give me more. So if you look at this next chart, this is about dopamine release in the brain, and you'll see, and there are variations of this. I've seen some where it looks at food, it looks at romantic interest, it looks at sex. All of the normal responses look kind of like the diagram on the left, right? So let's say that 100% is the normal amount of chemical in your brain. Food, a really nice meal, a big piece of chocolate cake, that tells your brain, hey, that's good. Let's remember that. Remember that chocolate cake is good. If you look at what amphetamines do, and I think this is actually specifically methamphetamine, this it turns your brain on 10, right? So it tells your brain, hey, this thing, you really got to remember this because it's really important. And so that is the hijack, right? So the reward motivation circuit, the thing that says, hey, let's remember it, drugs get in there and interfere with that. Um, and that creates this sort of unhealthy pattern. If you remember back to the chart with the ups and downs, that is what that person is seeking. That person is seeking that rewarding behavior. And again, whatever was done, that's what was for survival. That is how the hijacked brain says that substance equals something really important or really central to my survival. I'm going to do it. Unfortunately, your brain doesn't talk to you. Your brain just does what it does. So it's not that people know this, but we have this information from decades of testing and research. So okay, um, I want to show a quick video, and I'm hopeful that this works because I've done a lot of talking, and usually I like more interactive things where I can hear from the audience. I'm hopeful that if there are any questions that have come up, maybe you put them in the chat. Perhaps during this video is a good time to do the chat. But I think the important thing is that this is a little bit better explanation of what I just told you in cartoon form. So we'll see if it works, and if it doesn't, I may have to get support from one of my teammates. No sound. Correct? No sound? Okay. Sorry about that. And we may, actually, I think I may have identified the problem. Apologize for the text stuff. If you'll bear with me, I will need to unshare and reshare. With me. Hopefully you're taking this time to ask a question, or hey, if I've really upset your understanding of substance use disorder, please put that in the chat as well. I always like a good
I sent you a direct message with a question that we had from the chat, if you would like to answer that.
sure. Um, okay. You can probably hear the sound coming through my speakers. Yep, let's see the chat question. It says, how can a supervisor employee encourage a treatment plan and remain professional while reminding the team, as many of us did via the awareness campaign? So professionally and respectfully have that delicate conversation. Okay, that makes good sense. And I think the important part for someone that you feel like has a challenge is communication and simple communication, right? About, if you think about sort of the chart of things where we were before, and I guess I'm not screen sharing anymore. Sorry, Jennifer, are you still with me?
Yes, sir, I am. Would you like me to share the video now or help with
Yes,
this?
please. Yes,
Okay.
please.
All right, here we go. Hear it? Okay.
So, if we could, very good. So, and it's been pointed out to me that only shows half the story. My recovery experience is that wherever that dark time is, and if you notice the video sort of progressively got darker and darker, whenever that is, there's an opportunity for help. And so I want to go back and answer the couple of questions. I think my audio was going in and out, but I was in the process of answering a question around encouraging someone to seek help, but keeping that professional distance. And I think that this is an important question. And the answer I was beginning to give was about communication and just simply asking if a person is okay. The numbers about substance use disorder is that about 1 in 10 people in population suffer from a substance use disorder. Unfortunately, 9 out of 10 of them do not make it to treatment, and that's something at National Council that we're trying to improve that number and make sure that more people have access. So for that employee, very simply, are you okay? Is there anything you need help with? And here are some resources. And I don't, one of the things, and I'll go back into my presentation in a moment, but one of the things that we didn't talk about, if you remember the list of illnesses to begin with, the chronic ones, cancer, diabetes, hypertension, all of those, you don't typically hear things like, well, if that person just used their willpower, they wouldn't have epilepsy. Or if that person just used their willpower, they wouldn't have cancer. And there's plenty of truth to the idea that people that get those conditions, it's not always behaviorally based, but sometimes it is, right? So if you look at someone with lung cancer, there's a good chance that their behavior created the conditions in their lungs that were favorable to the development of cancer. If you think about hypertension, that extra cheeseburger might have that in a behavioral way, that extra cheeseburger might have an effect on your hypertension. So those things are typically not said about the other conditions, the other chronic conditions, but they are said frequently about substance use disorder. So
We have someone with their hand raised.
Okay.
Can we go ahead and let them
Sure.
go right ahead?
Oh, I didn't know you could do that. I prefer to talk to people. Hello, hello. Okay.
Marcy, are you able to unmute?
I did not intend to raise my hand. I'm sorry. Must have clicked on something. Sorry.
What
Oh.
questions do you have, Marcy?
I didn't have a question. I must have clicked something by mistake. Sorry.
I was trying to put you on the spot because
My
I like the
apologies.
back and forth. Okay. Let's see. Also, I'm glad I see a comment here from Jennifer around literacy and being able to talk about it. I think that a lot of the stigma, which I didn't spend a lot of time on stigma other than just the first slide, but a lot of times stigma prevents people from talking about this. But if you put this in a different context, you have an employee, that employee has a giant lump on their neck that looks very scary from a healthcare perspective. I believe most of us wouldn't hesitate to say, hey, there's this big thing on your neck. Have you had anyone check that out? Have you talked to anyone? Is there anything we can do to help? So a lot of times that reluctance is about stigma. So there are some professional boundaries around healthcare issues, right? And we are talking about a healthcare issue. So I would be maybe hesitant to label someone and say, hey, I think you're a person with substance use disorder. Here's what you need to do. But that doesn't mean we can't have the conversation. So other questions? Anyone? Oh, I see one here that is someone suffering from a substance use. Oh, by the way, and I'm not word policing. You can call it whatever you like. I say substance use disorder because the term substance abuse is actually, we don't we don't really think of it in that way. We're not, the label of abuser is a substance abuser is something, again, back to stigma, is something that can be harmful. But cured, it's a chronic condition. So there's not, to this date, there's not a cure. What there is remission, and that's, so from a medical perspective, I would be described as someone's been in remission for 20 some years. But there's not a cure necessarily. I assume if I were to expose my brain to the same substance, I would get similar results that I got before. So it's not really a matter of curing, but like if you think about cancer, right? There's not a cure per se for cancer, although here we're getting close. But people go into remission, and sometimes people go into remission for the rest of their lives, and it never affects them again. Sometimes people go into remission for a short period of time, and the cancer returns. So, the other part of this question: are you more likely to become addicted again, even if it's been years? Yes, the brain remembers, right? Those pathways that are carved by dopamine being flooded into your system, the brain does remember, but at 5 years of remission, the math says that people are at the same risk level as the general public. So that's really the only metric that we have. Again, not a cure, but after 5 years of consistent recovery and the lack of chaotic behavior around substances, we say that someone has reached a threshold where they are about the same as anybody else in society. Anything else? Anxiety and depression require medication, or does that open the door to substance use? So anxiety and depression are also in the DSM-5. They're also conditions. They also occur on a spectrum. I was actually having this conversation with my wife the other day, that anxiety and depression have definitely become more popular as descriptors, and there is such a thing as clinical depression, major clinical depression, severe anxiety. These are designations made by healthcare professionals, but we seem to hear a lot more talk about just general anxiety. So to answer the question, I can't recommend medication or not. There are plenty of non-medical therapies for anxiety and depression. The thing with the medication is it's something that you can measure, and plenty of people use those substances. I don't, specifically the antidepressants are not typically habit forming, but anxiety, one of the medications for anxiety are benzodiazepines, which are very habit forming. So it's definitely a case of making sure that you're informed about what you're taking, and always consult a professional, not me. We always want to engage professional support on this stuff. Okay, and I think I've covered all the questions I see in chat. I was hoping for someone to give a little pushback or a little disagreement, but I guess I can't get everything I want. We're going to go back to the presentation just for a couple slides, and then we will see if there are any more questions, and I'll be out of your hair. Okay, so just a couple of closing comments or closing thoughts. So number one, substance use disorder is treatable. It is chronic, but is a treatable condition. We have medications, we have therapies. One thing that I'll add from earlier in the presentation, when I was showing you the list of drugs that are available for treating other conditions like hypertension and heart disease, et cetera, is that there are entire classes of drugs that will treat that condition. In the substance use arena, there are really only 4 medications that are FDA approved that treat, and they don't treat all of the conditions. So they treat opioid use disorder, alcohol use disorder, We are working on something for stimulant use disorder, not we, National Council, but I mean the medical community is. The only thing that is really effective in the space of stimulant use disorder is something called contingency management, which don't want to get into the details, but it's something that has shown evidence to work for stimulants. Changes in behavior are associated with changes in the brain, and this is a tough one because sometimes the behavior of people with substance use disorder is sometimes shocking and outrageous, right? And I say that as a person with the condition. So it is not, we're not looking to absolve anyone or say it doesn't matter how people behave. People need to behave, you know, in sort of in agreement with the social contract, right? We don't want people doing things that are antisocial. But what you are seeing when you're seeing someone, specifically we get into the area of severe substance use disorder, you're seeing someone whose brain has been compromised, hijacked is the term that I use, and they're not necessarily operating as their best selves. The chemical involved with that is dopamine. So it's not, so a person that takes drugs, what happens in the brain is not that well, in most cases, it's not that the drug itself is in their brain, it's that the drug is producing the release of dopamine, and that's what's messing it up. But in the case of like, there are actually only two substances where the brain manufactures or where the brain actually accepts the drug, and those are the opioids and nicotine, as it were, which might point to why they're so difficult to quit. And I think most importantly, if you remember nothing, I know I've said a lot of scientific jargon, I apologize for that, but the thing I think to remember is that even though the brain changes, it is possible to recover. There's an entire community of people in the world that are recovered and living their best lives. So help is possible. And I promised you some supports. I wanted to, so on the left, these are sort of general supports that are available to people with, for the most part, with some sort of insurance. The mutual aid groups and peer support are free. Holistic and alternative therapies are not free and conceivably not covered by insurance. But for the most part, everything that you see here can be attained. On the right, if someone you know of needs treatment, findtreatment.gov is it's a decent identifier. Like anything else that you see online, please check your sources. Please make sure that you're not there are some unethical practices out there, but findtreatment.gov is government run and curated by them, and usually pretty solid. And then for acute crises, 988, initially it was sort of brought into the world as a suicide and crisis lifeline. There is a special focus within the 988 organizations around substance use disorder and substance use treatment. So feel free to call them and see what they can recommend. So that's basically it for me. I am interested, and I haven't been paying attention to see if there are any other questions. Oh, I do see a great one. Great question. Can using substances at a younger age cause development issues? So specifically around cannabis at a younger age has been shown to make some changes in brain chemistry and not good ones either. And the other thing is age of first use. When we look at all the people that have substance use disorder, a large number of them started use at a younger age. So it's a risk factor, and keeping kids from even having them delay their first use of substances is going to be a good thing. Okay. Alcohol, wait, let me make sure I didn't miss one there. Okay. Alcohol tends to be a go-to after work. For our industry, could you provide some alternative suggestions for winding down? Okay. So alternative to that de-stressor obviously is I'm a big I do a lot of meditation. I make sure that and that if you're new, that probably sounds kind of weird and culty, but spending time in quiet reflection is useful. There's physical activity that can be done. There are something that I take part in all the time. So I go to events where there's alcohol being served, and I don't consume alcohol, is mocktails. I've developed a passion for non-alcoholic mixed drinks, and I think there are even some sort of fake alcohols out there, but it's not necessarily a requirement to have alcohol in a mixed drink, and I've had some pretty tasty ones. Like I'm a sucker for a virgin margarita. So and just in general, other things that can be done. If you there there is a pathway called moderation for people. It's not to stop using a substance, it's just to use the substance less. I know plenty of people that have sort of moved into a moderation plan. We haven't talked really about harm reduction. Harm reduction is a strategy to reduce the harm to the person using the substances. So say someone has been consuming something, I was going to say heroin, but heroin doesn't really exist anymore. It's all fentanyl now. But someone's consuming fentanyl and they decide that what they want to do is consume less fentanyl and maybe switch to alcohol. The risk factor for consuming alcohol and the risk factor for consuming fentanyl are very different. Alcohol is metered, it's measured. We know what the dosage strength is when you drink a shot of whiskey. Fentanyl, you get what you get. So it's definitely a safer bet. Okay. Let's see here. Undiagnosed substance disorder considered a disability. Interesting. Undiagnosed, so disabilities typically are from a legal perspective, disabilities are usually around diagnosis of some sort. But I know that specifically with the business that you guys are in, you you may see someone, maybe a possible tenant that is that you think has substance use disorder, but until there's documentation and a clinician says yes, this person has SUD or one of the specific ones, AUD, OUD. Until someone says that and documents it, it's not really a thing. That I'm not a lawyer, though. I'm sure you guys have lawyers in your midst. That would be a question. That'd be a question for them. And absolutely, I'm with you on. I'm sorry, I'm reading the chat and responding. It says, I don't want a pilot flying my plane under the influence, and I don't want my property operated by someone under the influence. Those are reasonable thoughts. The question is, what do we do about that, right? So for the pilot, we don't typically know until after the fact, but I believe that to be a reasonable statement to want someone that has your safety or your property around to not necessarily be actively using the substance. So I do want to differentiate though between someone that has substance use disorder and someone that's actively using the substance. Someone that is actively using the substance may or may not have substance use disorder, and the drugs do what they do. They compromise our ability to understand our surroundings, control our motor functions, all of that. So 100% agree that you don't want that. But the person with substance use disorder, for example, I'm a person with substance use disorder. I'm not capable of flying a plane, but I'm perfectly capable of managing a property. So I just wanted to make sure that we're distinguishing between those two. Oh, I have positive response on mocktails. Glad you guys like them. I think they're good. I've also never gotten a hangover from a mocktail. But I think I'm to the end of the questions. But I will pause 30 seconds and take more. I know I think we're out of here at 3. Is that correct? Okay, so I might give you time back in your day. Oh, one last thing. I was just going to put my contact information up there. For whatever reason, I am Zoom challenged today. I'm usually pretty efficient with it, but today is giving me a bit of grief. And that's my contact info. Pretty easy. Philip R at thenationalcouncil.org. We are absolutely, I know you've been having mental health stuff this week. Turns out substance use disorder is in that same book that identifies all the mental health disorders. So there's a connection. The actual numbers are between 40 and 60% of the people that have a mental health diagnosis have a corresponding substance use disorder diagnosis. So I don't know if birds of a feather is the right analogy there, but it is not uncommon to see both of those, and most of these are treatable illnesses. So it's just some sort of fire alarm.
Gentlemen, your attention please. An alarm Ladies and gentlemen.
So we want to make sure that Phil is staying safe today as we hear the fire alarm in the background. So I just want to thank everyone for being a part of the conversation today and know that there is more to come throughout the rest of the week, whether it's the sessions are being offered in the afternoons or the other events that are happening. We are very grateful for your commitment to learning more, to building your awareness, and to finding new ways to understand the people that walk beside us or work beside us. So Phil, thank you so much for being a part of this, very, very much. And we do have a few minutes left if there are more questions, but I also wanted to make sure Phil was being safe as we heard those alarms.
I am safe. It repeated a number of times, but I think it's done now. And it's just says be still. So that's what I'm doing. I'm being still. And said there's my contact. And if there's nothing else, I guess we can go.
I know Tiana has some resources to share. So Tiana, some final words from you.
Absolutely. So I put our mental health awareness page on the chat. Once again, thank you so much for joining in, being vulnerable, and talking and asking these really important questions that really do exist within our industry. Thank you so much to Phil and Jennifer today for coming. And tomorrow we have another fantastic speaker, so we hope that you will tune in. Thank you so much, everyone. Have a great day.